Hello and welcome to the Racial Equity webinar series. I'm Kinkini Banerjee, the Senior Coalition Relations Manager at USBC, and it's wonderful to have you join us for this session. As you know, this bi-monthly series was launched last October, and it's part of our efforts to create a model of culture, inclusion, diversity and equity within USBC and our network of members and organizations. The purpose of this series is to build the capacity of the breastfeeding field to apply both an equity lens to the work we do to inform and guide our strategies, as well as a mirror to our own organizations, our own internal structures, cultures, and policies that might be creating barriers to true equity. And we are very glad to bring this series to you because of funding support from the W.K. Kellogg Foundation. USBC the website houses more than 20 online learning communities on breastfeeding related topic areas, from the Surgeon General's call to action and many others. And these learning communities are open to all site users. So explore and join the learning communities that, visit them, see what you think of them, and join the ones that are of greatest interest to you. So the Racial Equity Learning Community is also a fabulous place to have a deeper engagement and ongoing learning in this important issue. So we have webinars on the odd-numbered months, and then we always have, following the webinar, we have a blog post that's associated with the webinar topic, and this is done in the off month, and it's intended to continue the learning and discussion among us. So we have a file library with a lot of great resources on equity from our speakers, reading lists from our presenters, as well as from all of the folks on this reading list. It's a curated one, really good one, and we hope that as you join our webinar today, you will also join the learning community if you aren't already a member. So it's www.usbreastfeeding.org/equity-community. And there are many ways to get onto the community. If you go to About Us, you can see diversity, inclusion. You can click on that and it'll take you to the learning community. If you go to coalitions and click on Racial Equity Webinar, the page will also take you. So there are many, many ways in which you can access this learning community if you don't remember the vanity link. So this is the fifth of the session. We began our session with the first one, which was a report from the Center for Social Inclusion, which said removing barriers to breastfeeding, a structural race analysis of first food. And in September, we discussed the report. And in November, we had a very interactive session where we had small group discussions of talking about the report. How do we now translate this to action? And that was a really great session as well. And thank you to so many who joined. And our last one in January was Breastfeeding Moms' Voices Across America, a conversation. And we had Mona Lisa Hamlin, our USBC board member, facilitate a conversation with moms. And we heard perspectives from African American, Native American, and Latina cultures about what their experiences are and what we as folks in the field need to hear directly from the moms' voices. It was a great way, and all of these previous sessions are recorded, archived with handouts and other materials on our Racial Equity Learning Community and in the public webpage. So again, if you missed a live session, you know that you can always come back and join and access these important learnings at a time of your convenience. So a few logistics for today's session, because we have so many participants. All attendees are in listen-only mode, but we do encourage you to interact as much as you can and send us questions. So submit your questions at any time during the webinar, and I will moderate and pass them on to our speaker. So here's how you do it. On the right side of your screen, you should see a control panel. If you don't see it, it might be minimized. So click on that orange arrow tab and it'll pop back out, and scroll down through the different tabs, and under The audio tab is the one which says questions. Just click on that tab and it'll open up a text box for you to type your question in. And if you have any audio issues during this session, please send an email to coalitions@usbreastfeeding.org, and our staff will try their best to help you with any audio tech issues you might experience during this session. And that brings me to today's session, building cultural safety into lactation care. Cultural safety is a concept that comes from the Maori of New Zealand. It's the idea that only your people themselves can define what is culturally appropriate for them. This concept applies very aptly to African Americans here in the United States who suffer from ongoing racially based perinatal health inequities in the area of breastfeeding promotion, also in the area of breastfeeding promotion and support. So in this session, we will explore what culturally safe care in lactation looks like for African Americans. And I am delighted to introduce our presenter for this session, Sherry Payne, who is the Executive Director of Uzazi Villiage. Sherry has a Bachelor's of Nursing and a Master's in Nursing Education, and is also currently pursuing a doctorate in nursing education at Walden University. She is also a student of midwifery working towards the CPM credential. She's an internationally board certified lactation consultant and a certified nurse educator. She is, as I said, she's the executive director of Uzazi Villiage, which is a nonprofit dedicated to decreasing perinatal health disparities in community of color. Ms. Payne's accomplishments and leadership are extensive. She's an editor of the Clinical Lactation Journal, sits on the board of the National Association for Professional and Peer Lactation Supporters of Color, or NAPLC, and is as the chair of the IBCLC committee. Ms. Payne also serves on the local Fetal Infant Mortality Review Board. And she was recently selected to be a member of the First Foods Racial Equity Cohort, a very select group working to eliminate racially biased inequities. So many of you have heard Sherry Payne speak. She presents at professional meetings, and we are so honored to have her today. She's actually presenting and participating at the Breastfeeding and Feminism International Conference in Chapel Hill, and just has found a quiet spot in her hotel lobby to do this important topic with us. So I hope you will engage in this important session as we learn about a topic that's so vital to us as we work together to dismantle the inherent structural racism that is present in perinatal health. And with that, I'm going to turn it over to Sherry. Welcome, Sherry.
Thank you, Kinkini. Welcome, everyone, to the presentation today. I'm very excited for all the folks that could join us, and for those who will be listening at a later time. So thank you very much for taking time out of your busy schedules to be with us and to hear this content. I have instructed Kinkini that I will be taking questions all throughout. I will also be saving time at the end for questions, but feel free to type in your questions, and then Kinkini will share them with me verbally. So let's get started. So today's talk is cultural safety, building cultural safety into lactation care. This presentation will specifically focus on African American lactation care, or lactation care directed at African Americans, because that's the cultural group that I have my expertise in.
Sherry, this is Kinkini. If I can interrupt, we don't yet see your screen.
Oh, you don't? Well, I'm seeing it. Let me see. Oh, I see what I need to do here. How about that?
It's perfect. Thank you.
All right, thank you. Sorry about that, my apologies. A couple of things you need to know that, as I was saying, this will specifically be on the topic of lactation care for African Americans, although I always hope that the audience will find information that might still apply to other racial, ethnic, and cultural groups. But the examples that I'll be using here today are specifically on African Americans. Couple of disclosures. And that is that I have nothing to disclose. I have no conflicts of interest, and I would ask that the PowerPoint not be shared without permission. Kenny, I'm not having luck advancing my slides.
Okay.
I didn't have this trouble earlier.
Can you just click on the slide and then do page down, or the down arrows? See if that works, if you can find the prompt.
Yes, that did work.
Okay.
Yes, that did work. Thank you. All right, so those are my disclosures, which I already verbalized. And before I start, I want to say a word about the photos that you're going to see in this presentation. I want to give credit to the photographer. There's a photo on every slide, so you're going to see a lot of photographs. These photographs were taken at my organization, Uzazi Village, and these are all photographs of Uzazi Village clients. These photos were taken by Aaron White, who's a professional photographer and who specializes in taking photographs of breastfeeding mothers. So I hope that you will enjoy these beautiful images. We've loved them so much at Uzazi Village that we're taking some of them and turning them into educational posters. But in case you're wondering where these images came from, they originated at Uzazi Village, and they are all photos of families that we serve. So let's start with a definition of cultural safety. As our hostess mentioned, the concept of cultural safety comes from I know I'm going to pronounce this wrong with my American accent, what we call the Maori people, but since I happened to run into an actual Australian at the conference here this morning, she told me that it was really pronounced Mora, which my tongue definitely is not used to saying it that way. So please forgive me if I lapse back into my American accent and pronounce that wrong. But it comes from New Zealand, from the Maori people, and cultural safety is defined as the effective nursing practice of a person or family from another culture, that is determined by that person or family. So it is care delivered in a way that is defined by the person receiving the care rather than the person giving the care. And when I started, when I discovered this concept of cultural safety, I was immediately intrigued. It was a concept created by indigenous, previously colonized people. And the more I read about it, the more I saw application to African Americans here in the United States, whom, of course, don't typically self-identify as indigenous, but certainly as an oppressed people group living as a non-dominant group within a dominant culture. So subject to a lot of the same concerns and risks. So I observed a lot of crossover in the concept that related to how African Americans live in the United States, how they're perceived, how they're treated, and in the healthcare system, and how that impacts health outcomes, including breastfeeding outcomes. So for those who aren't familiar, I'm going to go back just for a minute. For those who aren't familiar, African Americans do suffer health disparities, grave health disparities, including in the area of lactation. African American women are much less likely to breastfeed their infants than dominant culture women are. And while there are a lot of reasons for that, some historical, some current, some policy, some cultural, there are many, many reasons for that disparity. This idea of cultural safety does address some of those issues. So a lot of information in my talk today comes from the article, Identity, Ethics, and Cultural Safety, Strategies for Change. And this comes from an Australian nursing journal. I found this article particularly helpful for breaking down some of these ideas in the way that cultural safety expresses itself and what we can do to enhance cultural safety. So you'll notice a lot of quotes in the PowerPoint as we go along. They're all from this particular journal article. So I want to start with the introduction here and pull out some of the themes that are expressed in the abstract. Cultural safety demonstrates ways in which culture and the sense of self are connected to safe and ethical care for patients. It is argued that transcultural nursing and cultural competence preparation have tended to depict the diverse patient as other, while reaffirming the hegemony of dominant culture. When caregiver interactions lack critical reflection, unequal treatment and poor patient outcomes are often the result. So in this discussion of cultural safety, they immediately bring up the concept of cultural competence, which is a concept that I've long had difficulty with because it did seem insufficient. And this definition of cultural safety goes right to the core of why it's deficient. So I want to read further. Engaging in personal and professional reflection can help healthcare workers understand their culture's relative power and privilege. It is suggested that intercultural interactions need attitudes and skill sets that support cultural needs instead of reaffirming dominant influence of one culture. So I'm going to go back a page for just a minute. So one of the things that I came to understand as I studied cultural safety more was why I had that nagging feeling that the standard of cultural competence was inadequate. And that is because cultural competence really focuses on knowledge and not action, whereas cultural safety has to be demonstrated in a way that a person practices, whereas cultural competency typically is thought to consist in taking a class or two or some extended training and gaining certain cognitive knowledge, and then just sort of checking off that requirement as done, that you've had your cultural competency training, and so that requirement has been met, and then you go on to other things. Whereas the concept of cultural safety is never ending. It's ongoing. It's constantly coming back and coming back to this reflection, to analyzing your choices and your interactions and your communications, going over them, reflecting on them, and deciding how you can do better. That is an integral part of cultural safety. So by its very nature, it's a dynamic process. It's an active process. It's not you can check off a list as having done and then keep moving. So this is why I think this idea, though it comes from New Zealand, is a good fit for dealing with African Americans in the United States, because it's not something you can do once and then say that you've done it, but it calls for practical, everyday, lived application, and then reflecting on that application, improving that application, and then doing better the next time, or making some improvement for the next time, and then analyzing those interactions as well. So it's never ending. You're continually learning how to provide culturally safe care. Okay. A lot of this is grounded in ethical principle, and those ethical principles include autonomy, justice, non-maleficence, and beneficence. So we'll take each one at a time. This is one of my favorite photographs, by the way. What does autonomy look like for African Americans in the U.S. healthcare system? And to think about that question, I thought about autonomy and people from oppressed groups. I thought about how difficult it is to manifest autonomy in healthcare across the board. It requires informed consent. It requires people being able to advocate for themselves. It requires people having a voice, and that voice being heard and responded to. And often those things don't happen in the healthcare system, or it can be very difficult for those things to occur in oppressed groups, of which there are many here in the United States. I think of my experience working with African American mothers who are planning or have an intention to breastfeed, and I very routinely hear those mothers tell me that no one ever spoke to them about breastfeeding, no one ever asked them about breastfeeding, and often when the topic is not even broached, it's a lost opportunity for those mothers to get the support and the help they need. Here in the U.S., there's often an assumption in the healthcare system, because African American women do breastfeed in lower numbers than other racial groups, that they won't be interested in hearing about breastfeeding as an option. And so when that assumption is made that this patient is African American, she's probably not going to breastfeed her baby, she probably doesn't want to hear about it as an option, then it represents a lost opportunity to support a mother who may very well have had an intention to breastfeed, or to inform a mother who's never been exposed to that option. And so that's one example that I think of, but there's a great deal of loss of voice in general when African American individuals are accessing the healthcare system. They're often not heard, not seen, and it does compromise this idea of autonomy, which is a type of self-determination in their healthcare choices when they lack all the options and information they need to make informed choices. The principle of justice, moral rightness, or being fair and equitable. So what we know about African Americans interfacing with the healthcare system is that many outcomes are inequitable, breastfeeding being just one of many. And a great deal of our work at Uzazi Village is predicated on creating social justice where there's very little of it. And that is enacting solutions and strategies to equalize or in some way improve health outcomes for African Americans. So our work is very much, as we see it, social justice work, because when African Americans have poor health outcomes, it's not just a result of bad choices on their part. There is institutional harm being done, there's institutional neglect, and we're going to talk a little bit more about that in just a few minutes. Non-maleficence is the next ethical principle. It means first do no harm. But of course, if the listeners know anything about African Americans interfacing with the healthcare system in the United States, you'll know the harm has already been done. And there's a tremendous history in the United States of African Americans being harmed in the U.S. healthcare system, from medical experimentations that began in the time of slavery and still often go on today, to the present day in different forms, to not getting equal care, to not getting adequate care, to being recipients of low quality care, to not having access to any care. African Americans are very much harmed by the healthcare system. And it absolutely influences African American attitude toward healthcare and interfacing with the healthcare system, in the sense that there's very little trust. So that sense of trust with the healthcare system has been disrupted. There's really not been any attempt on the part of the healthcare system to repair that distrust. And so the harm is historic, the harm is pervasive, and the harm is ongoing. So this is definitely an issue that has really never been addressed, and African Americans have not been given a reason to restore their trust that the healthcare system is going to treat them well, or provide them with quality care, or make sure that they have equitable access to that quality care. Beneficence, do good. And again, I believe the current system misses many opportunities to do good by African Americans. And when it comes to lactation care, if we fail to invest time and energy in a mother regarding breastfeeding education, because we assume she won't be interested, then we've also missed an opportunity to do good. If we fail to sit at that mother's bedside, give her eye contact and unharried time to devote to listening to her concerns and her questions, then we've missed an opportunity to do good. If we are not practicing evidence-based care in the institutions where African Americans seek their health care in large numbers, and we cling to archaic and outdated practices that are harmful to mother-baby dyads, then we have also missed an opportunity to do good. So let's shift to a new paradigm. Let's talk about cultural safety versus cultural competency. And I've already alluded to a few of the differences. We're going to explore them a little more in depth. So here's some dominant culture assumptions, or some assumptions of dominant culture norms. One is the assumption of normalcy. So it may be that dominant culture folks may not think of themselves as having a particular culture at all. If you ask them about their culture, they might say, oh, I don't know. I don't have a culture. I'm just normal. Meaning they represent the norm, which means, of course, that anyone that doesn't share their representation is not the norm and is therefore other. So here in the United States, life for African Americans is rife with the indictment that they are other. So everywhere they turn, the assumption of normalcy does not fit them. And this happens to be the case in lactation as well, where a mother might hear that her breasts are too pendulous, or her nipples are too big, or this or that type of comment about her physiology that insinuates that her physiology is not the norm. So it's important to be careful of sending those kind of subtle messages that you don't belong, you're not the norm. And it's interesting that those messages can even be passed along, not just by someone's verbal comments, but even the choices that manufacturers make when they're creating assistive devices and products to help with breastfeeding. And I noticed that most recently by helping African American moms who tend to have higher BMIs and tend to have more pendulous breasts, helping them with breast pumps, when I noticed that the typical phalange size that was used was almost routinely too small for African American women's nipples to fit inside the phalanges without rubbing against the edges, being abrasive, causing discomfort, and even tissue damage to the nipple. And after a while, we just made it a practice at Uzazi Village, where we have a breastfeeding clinic. We just made it a practice to keep larger phalanges on hand, so that when women came in, if that was the issue or one of the issues, we could immediately change out to a larger phalange, and we just had to keep them on hand. It was so common of a problem. But even something like that sends the message that, you know, if you had a normal breast, it would fit this size phalange, and this is the size of phalange that we've deemed is the norm. So the messages about normalcy are pervasive, can be very intricate, can be very small. It doesn't have to be something that hits you over the head. But African Americans constantly receive the message in healthcare settings that they are outside the norm. Another dominant culture norm assumption is that illness is the result of poor choices, that, or worse, that it's genetic deficiency. And in the case with either of those, of course, the problem belongs, or the root of the problem is rooted in the individual. Where at Uzazi Village, we take the view that a lot of the problem is really in the system, not just the healthcare system, but really in all the key institutions of American society. But of course, we're dealing with healthcare here. But the root of a particular woman's trouble with breastfeeding isn't necessarily just tied to her own health behaviors, but it's also tied to her environment. And when she's interfacing with healthcare, it's very much tied to systemic racism as it is manifested in healthcare. So that can absolutely be a part of the picture. So much of the focus, oftentimes when you're talking about healthcare disparities in communities of color, focuses on the behavior of individuals within those groups. And I'm not saying that there's not a place for that, there absolutely is, but more time and attention needs to be put on the systems that those individuals are having to deal with, systems that may not be in any way attentive to their needs, and that may actually be punitive. Another assumption is the failure to see a lack of choices for non-dominant cultures. So dominant culture providers, and I saw this a lot in my experience earlier in my career as a labor and delivery nurse, and even as a nurse educator accompanying students to the hospital setting. I saw middle-class dominant culture nurses assume that what may have been low-income, non-dominant culture women had the same choices that they did, and that if they didn't make good choices, well, they just didn't make good choices. So there was this gross assumption that Everyone had the same choices, everyone had the same opportunity, everyone had the same access, and of course those things are often not the case at all, especially when economics come into it and you're dealing with low income, low resource individuals. Another assumption, the lack of knowledge of historical trauma, generational stress, social determinants of health, and biologic results of oppression expressed as disease. It's certainly my observation that I do see a complete disregard for these issues as they relate to health in the African American community. I always find it interesting that there is a distaste in dominant culture for discussion on historical trauma, and where I have never once heard anyone tell a person of Jewish descent, oh, please don't talk about the Holocaust. That happened in the olden days. That's not relevant now. We should just forget about that. I've never heard that come out of anyone's mouth, yet I hear that routinely when the historical trauma of African Americans is the point of discussion. So there, not only is there a lack of knowledge, there's a lack of social discourse and engagement on these topics. But I do see a diminishment of these factors and how they impact African American health, and I do see a lack of knowledge on the part of healthcare providers for understanding how these stressors play a role in African American health. So these are some of the norms that are some of the assumptions that have to be dealt with in order to make a shift, to make a change in how we perceive African Americans and their health as it relates to culture. So in the article, it offers this nice definition that cultural competence offers understanding of the cultural life ways of patients, and it does. It offers knowledge, basic facts, basic understandings, but the cultural safety goes beyond that it requires ongoing personal and professional reflection and an exploration of power relationships. And that power dynamic is key because we have to stop and understand who has that power, how is that power used. That power is often used to silence others, to render them invisible, and there's a complete lack of safety because of the power differential. And I often challenge healthcare providers when I'm speaking to audiences around the country, when have they ever personally been in a situation where they were the minority, the numerical minority in the room, and did not hold the power differential. And dominant culture people are very rarely in a situation where both of those things are true, where they are numerically in the minority and also do not hold the power dynamic in their favor. And so they, it can be difficult to have an understanding of what that really feels like, how easy it is to lose your voice and to lose your very presence in a situation like that. So cultural safety applied to the U.S. I want to talk about the colonization of the Black body here in U.S. history and as African Americans interface with the healthcare system. So since we're running close on time, I won't spend a lot of time on this, and it is absolutely something that I encourage folks to read up on if they're interested in some of these historical phenomenon. But just to list a few, going back to a discussion on the experimentation on Black women's bodies, Dr. Sims, known as Marion J. Sims, known as the father of modern gynecology, used slave women to practice his surgical techniques on until he perfected them. And he truly did make some medical breakthroughs, creating treatment for obstetrical fistulas that are still in use today. But those surgical procedures were done on the bodies of slave women. At other points in history, giving an example that's closer to modern times, experimentation with birth control is an example of something that I've seen go on in my lifetime, that often suddenly funds appear when new medications or treatments or procedures or come about. Suddenly there's funding to have these procedures or these appliances used on low-income women of color, and there are campaigns that go out to increase the appeal of these procedures or appliances or medications or whatever they may be. And certainly I've seen this in the realm of family planning. In fact, throughout history, Black women's, African-American women's fertility has been central to the whole issue of colonization of the Black body. During slavery times, African-American women were compelled to be fertile and produce as many offspring as possible to enrich their owners through the increase of their chattel through childbirth. Whereas in modern times, the opposite has occurred. There seems to be ongoing undue attention paid to Black women's fertility and how to decrease it, and continuous stream of programs dealing with family planning and contraceptive that focus on decreasing Black women's fertility. There have certainly been times in history where even sterilization, forced sterilization, or sterilization that was not quite forced, but was coerced, that have been used against African American women. So there have been many instances where the focus has been on controlling processes in Black women's bodies when it came to fertility. And to fail to see the toll that that has taken, and to fail to see how that has impeded trust in the healthcare system, is to overlook quite a bit. In the personal provision of healthcare, many miscommunications can take place. If you're assuming that as a provider, that just because you said it, that communication took place without any demonstration of how your communication was received or whether or not it was received, then there's more work to be done. It's important to ask patients what they heard you say, and not assume that just because you said it, that it was heard, or that it was heard in the same way that you intended it. And because the way that dominant culture people communicate and non-dominant culture people communicate is so vastly different, there is lots of room for miscommunications. So I once had a dominant culture provider ask me, how often do you think these kinds of cultural miscommunications or misinterpretations occur? And I responded, probably only every time you communicate. So I see this as something that happens fairly often, that it's very pervasive, and that we constantly don't understand one another, that recipients of care fail to adequately understand the full communication of the provider, and that the provider often doesn't even receive communications from the recipient of care. So let's talk about strategies for change. It's probably one of my other favorite, second favorite photograph out of the group here. So how do we change? So the authors of our essay here, who've been looking at cultural safety for a lot longer than I have, think reflection is key. Gain an understanding of whatever your history is in relation to the history of the people you serve. That helps to give you the background to walk alongside, which means, put yourself in someone else's shoes and to see things from their point of view, which I admit is pretty tricky to do. But to begin with even a desire to get it right, what I often see as a non-dominant person, non-dominant culture person in healthcare myself, is that when you're working within systems that deal with a lot of non-dominant culture people, that beliefs, biases, and stereotypes arise that become an embedded part of that system. And it's easy to just, after a while, go along with the party line. Oh, these people never do that, or those people never do this, or always do this. It can be much more difficult to cultivate that desire to really understand or to walk alongside. And of course, as I mentioned earlier, cultural safety doesn't exist in a vacuum. It should evolve over time. It should grow along with the person. So I've listed a few actions here, and we'll finish up with these actions that listeners, providers can take to cultivate cultural safety within their practices and within their institutions. So, action 1, examine every interaction for biases, negative assumptions, stereotypes. Ask yourself, would this interaction be the same if the patient were a dominant culture person? So this takes some introspection, and it takes some honesty on the part of the person doing this. And while the problem, the crux of the problem often lies with systems and institutions, individual care providers are impacted by the culture of the institution that they work for. And so it's important with your own personal interactions with clients that you aren't representing any negative assumptions that might be embedded in the systems and institutions that you work for. See through your client's eyes. Look around your workplace. What do you see? What does what you see tell you about the provider who works there? So try to see your workplace through your client's eyes. Is it a place that they can walk into and feel safe, feel welcome? Does the environment say, you're welcome here, we're going to take care of you here, we're going to listen to you here? What does that feel like from their end entering that space? Action 3, what populations do you serve primarily? What first-hand knowledge do you have about this group of people? Do you have friends or family who are part of this group? So how deep does your knowledge go? Have you just picked up a few stereotypes in the workplace, or do you personally actually know anyone within this group that you've interacted with on a more intimate or personal level that may have given you insights into the culture? It's pretty difficult to know, capital K, to know a culture without actually interacting on more than a superficial level with anyone who belongs to that culture. So, so I often offer making real friendships as a viable action to understanding a particular culture better. Not just friend buddies, or workplace buddies rather, but friendships outside the workplace, because workplace friendships tend to be very superficial as well. Has there been a misunderstanding during an interaction? Can you dissect what happened? Do you have someone in your life from that group whom you feel safe asking these questions? And I myself get these questions from time to time from dominant culture friends who want to dissect either a negative or a positive interaction and understand exactly what took place and how to improve in the future. Prioritization can be very different in families that are low income or have differing or conflicting cultural priorities. And I put in conflicting there because sometimes there can be a conflict with healthcare beliefs and accepted healthcare treatment. And that includes in the field of lactation too, where there are often very conflicting and competing beliefs about infant feeding and how that should proceed. But I do think it's a good reminder that folks in different life circumstances, let alone folks from different cultures and racial categories, may have very different priorities for their actions. And so it's not unusual for a healthcare provider to think, well, you should do this because this should be your healthcare priority, when the patient themselves may have other issues that they prioritize above that. And we might dismiss that patient as just being non-compliant or not being willing to participate in their own therapeutic regimens. We can dismiss them that way, but the issue may really be that they just have a different set of priorities and what should come first and which they should be investing their time and resources in first. Common language does not denote common understanding. Always ask for teachbacks. So a good question is, well, okay, tell me what I just told you, which is a line I often use with clients. What did I just say to you? And then that way I'm going to get their understanding. But I constantly remind folks that just because you're speaking the same language does not mean that communication is taking place. That came out of my observation that providers seem to be more careful and took more time with clients who spoke a different language because they had to. They had to make some concessions. They had to make some adaptations for the fact that this person didn't share the same language. But there was no such caretaking when the provider and the patient shared the same language, just an assumption that because the provider said it, that understanding was a given. And that's not the case. That's not always the case. Another great action, read texts that are historical, sociological, and anthropological in nature. I know who has time to read, but you can pop in a book on tape too while you're doing your morning commute. But if you're particularly interested in African Americans and reproductive health or women's health, then I love books like Killing the Black Body by Dorothy Roberts and Recreating Race by Kiera Bridges. Another good one to read might be The New Jim Crow, but there are Ta-Nehisi Coates' newest book that just came out. There's lots of good reading out there to be done if you have a knowledge deficit about the historical context of African Americans and the American healthcare system. And I'm sure that's true of every people group, whichever people group you have a knowledge deficit on. There's probably some really good reading out there that you could take advantage of that can help you understand a more historical context or a generational context that is impacting interactions and interfaces with the healthcare system in the present day. Join or start a conversation group for other dominant culture folks. We've actually done this at Uzazi Village. We call them our living room revolutionaries. And at our living room revolutionaries groups are actually book clubs. So we encourage folks who are interested in a deeper understanding of the racial divide in our country, especially as it impacts healthcare, to read books, and then we come together and discuss them. So we do it in a book club form, but you can just come together, watch a TED Talk, read an essay, or just have a topic discussion, break into small groups. There's many formats this can take. It can be centered in the workplace. It can be social groups in your neighborhood. But there's many forms that conversation groups can take where the goal is greater understanding of another culture and their responses to healthcare. So those are my action steps. And I went a little bit over the hour I wanted to go, but we still have plenty of time for Q&A. And I love all of my talks to be as interactive as possible. So I'm eager to hear some of your questions and have a little bit of dialogue back and forth. So Kenny, are you there?
I'm here, Sherry, and thank you so much for this terrific, powerful presentation. And I think you've just laid the case for how urgent it is that we really delve deeper into the issue of cultural safety, because as you said, cultural competency is something unattainable and also so inadequate by itself, like without this context. So we do have questions. We have a few comments that I'd like to read if possible. So lots of, positive feedback about the action steps you've taken, about how, if you could give us the book list. I wrote down the books as you were saying. And then also Laura Sinai says that, when we think about the Holocaust reference, and the reason in America we discuss the Holocaust is Americans were the heroes, not the oppressors. And now Germany has extensive written law about making Holocaust denial illegal, and they have museums to record the atrocities, and they teach it in school to avoid ever repeating this mistake. And one of the reasons is that we, as a group, responsible for Black oppression in the US, are very uncomfortable regarding our own history. And this discomfort has resulted in the opposite of Germany's behavior, and Americans are allowed to ignore and negate and deny the history due to our, sometimes distorting the causes of the issues, or even trying to whitewash slavery and equity issues. And so this discomfort that we have about not wanting to confront our own history, it leads to the kind of just pernicious issues that we see today. So thank you, Laura, for that comment. And
yes, Laura, those were some absolutely astute observations. I very much appreciate your comments. Thank you.
And then lots of agreement again about, having from folks in WIC or clinical setting talking about that they do understand that, how when you see it from the context of this is the norm, this is right, that you reduce it to behavior or the other, or this is normal, what you do is not normal. So one question is, what are some specific examples for way I can ensure cultural safety in my hospital IBCLC care I give? You've given a lot of suggestions. For example, do you have suggestions about encouraging exclusive breastfeeding when a mom says she just wants to breast and formula feed together. So this is a question. So did you hear that question again?
No, I heard it, I understood it, and it's actually a common question I get. And I definitely think there's some cultural beliefs embedded there. One of the histories, and thanks for asking about the book list. It didn't occur to me to make a slide out of that, but I absolutely do have a book list. I absolutely will pass it on to Kinkenny, and then she can let you know how she would distribute that, whether she puts it on the website or not. But yes, I do have a suggested book list. But the one book I haven't read yet, because to my knowledge it doesn't exist, is the history of breastfeeding in the African American community. Has been a really interesting history. And I think that history has to be taken into account by lactation consultants and other lactation professionals who are working with African American communities. So here's my take on that question. Exclusive breastfeeding is a fine goal. There's nothing wrong in and of itself with exclusive breastfeeding. I absolutely support exclusive breastfeeding if that's what a woman chooses to do. My problem with that standard applied to the African American community is that it presents some issues and some conflicts. If you know a little bit about the history of breastfeeding in African American communities, breastfeeding was at one time a norm. Breastfeeding, just like it was for Americans in general, it was how you fed your baby. And there weren't too many other viable options to that. But when the African American community lost breastfeeding, or when that option was eroded by the over commercialization of formulas in our community. And this same thing really happened with birth. This is how we also lost our midwives when African American bodies were needed to inhabit those hospital beds for birth. But breastfeeding was to a degree taken, and now you really have to be careful with the spirit with which it is restored. It cannot be, it cannot come across as something being imposed from outside of our culture. As far as I'm concerned, and our view of breastfeeding at Uzazi Village is that it absolutely is a cultural practice, one that has been generationally lost, but that we seek to see returned and preserved. But that this is something that belongs to us, that is ours to claim, not something that outsiders seek to impose. And so one of the problems with exclusive breastfeeding is keeping that as an imposed standard is that it forgets the history of the people that it's being imposed upon. That generationally now, we have not in massive numbers breastfed, and that while breastfeeding is being re-embraced, it is new. It is being restored, it is being re-embraced, but it is new to the culture. And a lot of African American women have knowledge of and comfort with formula and bottle feeding, And just to make the leap whole hog is just that. It's a huge leap. And a lot of women may not be ready for that. They may embrace breastfeeding incrementally. And that means combining, for some women, that means combining what's familiar with a little bit of what's unfamiliar. And often you'll see a desire for breast and bottle feeding, not because they don't think breastfeeding is wonderful, and not even because they might want to do it exclusively, but they're nervous about it. They don't know if they can be successful because it's a new behavior, and they want to mix it with a little bit of what's familiar to them. And so imposing exclusive breastfeeding can seem like an all or nothing proposition, or taking away what little power they have to be in their comfort zone about this. So it can be really tricky. Do I want every woman to exclusively breastfeed every baby? Well, sure I do. But I have to put that women who may be for the first time slow that when what they've chosen is in conflict with everyone around them and even with some of their own cultural ways of being. So we need to extend grace to African American women as they discover how integrating breastfeeding to their current lifestyle works for them. So I'm going to holding on to one thing while they grab of the old, while they grab a hold of the new, and carry them both forward so they can have some level of comfort about how their infant is going to be fed.
Very well said, Sherry, and so important. And this really ties into just gaining a better understanding of history and really understanding what the colonization of the Black body has done to, and the ramifications of it even today. So we will definitely be
Right.
there's a lot of interest about that part of your presentation too, about understanding, interest in gaining better understanding. So we will be sure to schedule webinars that looks very specifically into this as well.
Well, I tell
And
you, it goes back to that autonomy and making that woman feel empowered because the choice is hers, rather than imposing your will because you know what's best. There's a lot of difference in those two different mindsets. I'd so much rather a woman breast and bottle feed and feel empowered in her choice doing so than to beat her down and make her feel as though she must exclusively breastfeed when that's not where her comfort level is.
absolutely. And we have Charlene Burnett here who is saying amen. And, as you tell the stories of your struggle, will you, Sherry, talk a little bit about the work at Uzazi Village? I know that in community engagement, some of the comments that we are getting are that how do we, we wish we could have more African American speakers at our conferences, and it is about building that network and really getting to know the community. So you're not doing things to the community, but you're doing things with the community. There's so much inherent wisdom and strengths and insights and knowledge within the sphere of providers within your own communities, and how do we tap into it. So if you could talk a little bit about the work that you do at Uzazi in mentoring, bringing up.
Right. Thank you, Kinkani. That is so well stated and such a truthful fact, what you just said, and that you work with communities, not at them. And you can have me for your conference. There's my contact information right there on the slide. So I do travel and I love to speak at professional conferences, private workshops, whatever you have in mind for your institution or organization. At Uzazi Village, our breastfeeding related services include a free walk-in breastfeeding clinic. We also have a Pathway 3 mentorship program that we run because we always want to be cultivating both professionals of color and dominant culture professionals who have an understanding of how to care for communities of color. So we want to cultivate both those things. We have breastfeeding support groups. We have La Leche League, which we're the only La Leche League in our city that has leaders of color. And we also have Chocolate Milk Cafe, which is a breastfeeding support group that I've developed that is for African and African American families exclusively, so that those women, their partners and infants can come and discuss their personal struggles with integrating lactation behaviors into their lifestyle. They can have a safe space to come and talk about their specific concerns. So women in our community have their choice between attending La Leche League and attending the Chocolate Milk Cafe. And we also have breastfeeding and baby wearing classes, again, to support Afrocentric styles of parenting and restoring specifically Afro-culture parenting practices. And so our focus really is on supporting the African-American family structure and celebrating that, because African Americans take such a hit on pretty much everything they are and who they are and how they are, that at Uzazi Village, we really want to counter that with subtle and overt messages that say, your family is beautiful, your family is celebrated, your family is valuable, your family is worthwhile, no matter what that family structure looks like, it's celebrated here. So that's a little bit about Uzazi Village. I'm a lactation consultant. I run the 2-day-a-week walk-in clinic. I also oversee our lactation interns, is what we call them, who are part of our Pathway 3 program. In our program, we have established relationship with several of our community hospitals, community-based clinics, and pediatric practices that take our intern placements. So we actually have very few of our interns hanging out at our walk-in clinic because they're all out at their community-based sites, getting other experiences there too. So those are a few of the breastfeeding related things that we do. We also educate. We have our own curriculum for breastfeeding peer counselors, and we educate breastfeeding peer counselors as well.
Wonderful. Thank you, Sherry. We have another question from Anne, who's a doctoral student interested in breastfeeding among African Americans, and she would like you to speak a little bit about your experiences involving fathers in the breastfeeding work that you do.
Yes, I'd love to speak to that. The role of the breastfeeding father and the breastfeeding grandmother are critical in the African American community. So it's important to have the buy-in of the breastfeeding father, and it can certainly be critical to have the buy-in of the grandmother and other what I call women folk in the family. So the mother's life is going to be so much easier integrating breastfeeding behaviors if she has the buy-in of her mother, her aunties, her sisters, her cousins, because they're all going to be chiming in, and what they have to say can either help or hinder her in this process. So we consider the role of the women folk very important, and consider the fathering role crucial as well. We've seen fathering support make or break breastfeeding, and especially when the mother has difficulty, if the father is committed and encouraging and supporting, that can get her over several humps and keep her breastfeeding her baby. So we take every opportunity we can. Dads are welcome. Notice when I talked about Chocolate Milk Cafe, it's open to dads. When we have our baby wearing classes, we encourage dads to wear their babies and get their skin to skin time in. So the role of the father, if there's a partner in the picture, that person is included in all that we do, because one of my observations that I've seen over my career is that invisibility of the Black man as father. Not that he isn't there. What I'm talking about is the invisibility that the institutions bestow, that they treat him as though he's not there even when he is. So that's the invisibility I'm talking about. And so often I see Black men as fathers marginalized, sidelined, ignored, or worse, seen as a threat. So a lot of negative personifications placed on the Black man as father. That again is something we seek to overcome, and we embrace the Black man and his fathering role.
So true and so pivotal in this whole decision. So thank you, Sherry. And we are running out of time. I just wanted to say, for folks who wanted to know, APHA, the American Public Health Association, has a 4-part webinar series called The Impact of Racism on the Health and Well-Being of Our Nation, and it's profound. So if you can go to APHA and see the recordings of the 4, like name it. We have to name racism. It exists. Until we actually confront it, we can't do anything about it. And so we will continue the conversation. Sherry's going to write a blog that accompanies this very important topic of cultural safety, so we can continue our learning, continue our discussion through the process in the coming month, through April as well. And again, can't thank you enough, Sherry, for bringing this such a vital topic to us today. We do have, if there are any questions I haven't got time to ask you, we will be posting them on our page as well. So we'll try our best to get all your questions. But we thank you again for your time, and until next time, goodbye.
Thank you, Kim Kinney. Thank you, everyone, for listening.